For those of you who don't know me, my name's Andrew Tagg. I'm a paediatric emergency physician in Melbourne. And 10 years ago, I got an email from the lady in this front row, Tessa Davis. Dear Andrew, I've seen you on Twitter, and I wonder if you'd like to be involved in this little project I've thought up with a couple of friends that I met randomly online. Their names are Ben and Henry. We thought it'd be a really good idea to pool our research and our resources so we can all learn from each other. Let's set up a blog. I think we should call it Don't Forget the Bubbles. For us, it was a whole new beginning. I was a trainee, as was Tessa and Henry. Ben was an emergency consultant who knew far more than we did. But over the last 10 years, we have published over 1,200 blog posts with 250 authors from around the world. We've held 5 now in-person conferences and a couple of online. And that's all thanks to the support of you, our audience, the friends we've made along the way and the friends we've yet to make. So this afternoon is about new beginnings. I'm going to start today with someone who was with us from the very start. Neonatologist from Queensland, Jasmine Antoine.
Thanks, Andy. I'm on a helicopter. I'm in my flight suit. It's my second neonatal retrieval. Did I mention I was on a helicopter? It's really exciting. It's my first time on a helicopter. Do you think anyone's noticed it's my first time? But it's not a joy flight. I'm on a retrieval. Sitting next to me is a neonatal retrieval nurse who I met for the first time 2 hours ago. And across from me is an obstetrician, and he's holding an emergency caesarean section pack, because we're on our way to the delivery of preterm twins about 350 kilometres northwest of Brisbane. And as I sit there, besides my joyous we're on a helicopter, I'm also thinking, what if these babies need resuscitation? What if these babies need intubation? Resuscitation at delivery is pretty common. About 1 in 10 babies will need some assistance from us, but less than 1 in 100 require intubation and ventilation. If you're a preterm baby under 32 weeks, you're far more likely to require intubation, about 3 in 10 babies. But the most likely day for you to require intubation is the day that you're born. So the helicopter lands in the field. In the distance, I can see a Queenslander house, for those of you not from Queensland, and that's the hospital. We're greeted by all of the healthcare workers from the district. That's 6 of them. They're pretty happy to see us, because in this hospital and in this district, there's less than 2,000 people. They don't do deliveries there. They certainly don't do preterm deliveries, and they don't do preterm deliveries of twin babies. So as we walked into the delivery room, we'll call it, with all of our gear, we had a transporter cot, 2 ventilators, a giant red pack. There was 1 resuscitaire and 1 neopuff. But as I just told you, this was the delivery for twins. So the very lovely workers at that hospital had set up a second station. It was around the corner in the adjoining room. It consisted of a Perspex cot, an anaesthetic bag, and a giant bottle of oxygen. Yeah, that's what I thought too, hey? Now, labour was progressing really well, so I was ushered off to the kitchen, and I can't tell you this story without telling you about the best jam drops that I've ever tasted in my whole life. They were so good. A couple of hours later, the babies were born. The first twin came out flat. We took him to the resuscitaire. We provided stimulation, intermittent positive pressure ventilation. After a couple of minutes, he started to breathe. And so he went on to CPAP with the use of the near-puff. The neonatal nurse took over the airway, just as the second twin was being delivered. But she also came out flat, so we made space for her on the resuscitaire. I stimulated her, we gave her some CPAP via the anaesthetic bag, and she improved pretty quickly. So I transferred her to the Perspex cot. And I remember standing there. I had one baby, the neonatal nurse in the adjoining room had another baby, and we were both waiting and waiting for the babies to improve. At about 20 minutes, I'm still standing there with my mask, the anaesthetic bag, my hands cramping by this stage. I've got the air conditioner on to max heating. And you might recall that I was in a flight suit. So by this stage, I was sweltering and a sweaty mess. And we needed to make a plan because neither baby was improving. So we're calling out to each other across the room. Both of the babies needed intubation. Now, I'm not sure of how many of you in the room have performed a neonatal intubation, have assisted in one, have seen one, but it's a complex procedure that's difficult. If you're a junior clinician like I was at the time, your likelihood of success on first pass is less than 50%. It takes junior clinicians somewhere between 20 and 60 attempts at intubation to become proficient. If we're saying proficiency is you get it in within 2 goes about 80% of the time. Those numbers might seem high to you, but it's similar across other specialties. In paediatric emergency, in paediatric critical care, the number sits somewhere between 20 and 75. So what are the challenges with neonatal intubation training? Well, there's lots, but the main one is that we intubate fewer babies than we ever have before. We manage babies on non-invasive respiratory support. We no longer intubate to give surfactants. We no longer intubate and suction babies that are born through meconium that are apneic at delivery because that's been taken out of the algorithm. So there's less opportunity when you're a junior clinician to gain the skills that you need to be successful at neonatal intubation. Now, these training challenges aren't just confined to neonates, it's across medicine. We know that training takes lots of staff. It takes staff to actually provide the education, it takes staff to provide supervision. It's costly to train people. We work in a really mobile workforce where trainees rotate every 3 to 6 months. Sometimes people are changing health districts, changing states every year. And it takes a lot of time to be proficient in complex skills because complex skills by their nature are complex. They're multi-step processes. They involve the technical skill and non-technical skills. And what I mean by technical skill is my body's ability to get the job done. How do I move my hands? And non-technical skills are those interpersonal skills. How we communicate, how we work as a team, how we manage our workload. So today, as we talk about training through disruption, I want you to consider when you are learning and when you are teaching, what are outcomes of good learning for you? Who does your training focus on? Does it focus just on the individual? I really want to challenge the idea that if we provide more training to individuals on their skills, that we'll have better outcomes. Importantly, I want us to consider how we can make our training better. I want us to focus on the system rather than the individual. So all of us are learners and all of us are teachers. That's why we're here today at conferences like this. What are measures of good learning for you? When you ask yourself that question about the training you're running or the training you're participating in, I want you to think about 3 things. Skill acquisition, so the ability to be able to perform that skill, to become an independent practitioner in that skill. Skill retention, so once you attain that skill, to keep those skills for as long as possible, even if you only practice them infrequently, even if you only do that procedure yearly. and skill transfer. So that ability to do that skill no matter what environment you're in, no matter what team members come along with you, no matter the tools that you're using. Perhaps in your workplace, a measure of good learning is being able to intubate before you hit that 20 intubation mark. Perhaps it's being able to perform the skill even when you only do it every 6 months, so that you can still do it by the time you go to the refresher course. Perhaps it's being able to perform the procedure in the emergency department, but then when you respond to a MET call, also being able to perform that procedure with the assistance of the ward nurses, with the surgical team telling you the background of the patient. In my case, my ability to transfer my skills of intubation to that Queenslander with a new team, 2 babies, was really challenging. I intubated the first baby. We popped him in the transport cot onto the ventilator. Yes, okay, good. 1 down, 1 to go. The second baby, she had been in the Perspex cot, so we popped her on the resuscitaire. She'd had IV fluids, IV antibiotics. We gave her a rapid sequence induction. I had 2 attempts at intubating her, and I was not successful. She remained stable, and we made a plan about how we were going to manage her respiratory distress on the journey home. So I ask you, when you are learning and when you are teaching, who does your training focus on? If before I'd been sent out on that retrieval, I'd had some education about my technical skills of intubating, do you think I would have been more successful? No, I don't think so. Because success is not just dependent on us, the clinicians. It's not just dependent on our technical skills to be able to do the task. It's dependent on the system. And what I mean by the system is the task that we're performing, the team that we're with, the tools that we're using, and the environment that we're in. The interplay between those things. Success is dependent on the system. So let's talk about each of those. So the task. Well, we all know that the task isn't always as you think it is. There's this idea of work imagined versus work done. And work imagined is what's in the work unit policy or the guideline, right? The steps that we follow. But work done is what happens in the real world. What steps we actually take in our environment. And as we well know, they're often not the same. So why aren't they the same? They're not the same because when we're writing our work unit policies, we live in an ideal world. Ideal staffing, no one's sick on that day. Nope. An ideal environment, there's no bed block, no problems, everyone's been shipped back to their home hospital. We also know that when we ask senior clinicians to describe a process or a complex procedure, they miss out 70% of the important tasks and processes, 70%. So there's bits and pieces missing. But no matter, the intubation in that Queenslander hospital was not anything as described in the retrieval policy. So the people, the team, the individual, our experiences, how we interact together, how we manage workflow is important. Success is also dependent on the tools that we're using, the devices. Are they fit for purpose? Are they actually usable? It's dependent on the environment, the facilities that are available to us. It's also dependent on the organisation. The organisation being resilient to unanticipated events. The organisation being resilient, not us. A systems approach to training focuses on the fact that things can go wrong, steps and processes can go wrong, and we can still have a good outcome. So when I was out there in that Queenslander and I was sitting there for those 20 minutes giving Twin 2 her CPAP, I was also on and off the phone to the retrieval service. They wanted to know how long I'd be. I would like to know too, I'm not sure. Because they were trying to sort out assets to come and get us, to take us back to Brisbane. We had to troubleshoot the fact that the lovely local doctor was trying to get intravenous access for us, but he was unsuccessful. We had to troubleshoot the fact that whilst we were intubating Twin 1, who was going to manage the airway of Twin 2? We had a near-puff and we had an anaesthetic bag, but both of those pieces of equipment were unfamiliar to the local team. Complex skills are difficult, and they're difficult because they increase our cognitive load, and we heard a little bit about that earlier this afternoon. The cognitive load theory tells us that our working memory is finite, so when clinical scenarios overwhelm us, our learning is impaired. We know that novice clinicians who have high cognitive load perform poorer than those with lower cognitive load. So for peak performance, we should be thinking in training and in complex procedures, what are ways that we can manage people's cognitive workload? How can we reduce that? It can be simple things, checklists, printed maps of where the equipment should be laid upon. Having an environment that has lots of PowerPoints, so you're not looking around, where do I plug this in? This cord's too short, someone get an extension cord. Having gas and air plumbed into the right wall so we can line up our resuscitaire. The idea that if we train individuals better, poor outcomes won't occur is not true. It's an outdated idea. So let's leave here and reimagine our training. When we learn and when we train, let's be thinking. Let's think outside the box. Let's widen our scope of training. Let's focus on the system rather than the individual. And it's easy to do. I've worked in departments that have taught guided breathing as part of their advanced training teaching. Gone to escape rooms as a team building exercise. Seen pieces of equipment being thrown in the bin because they're no longer fit for purpose, even if one very senior consultant still likes to use that on occasion. Processes changed in the work unit policy because we know that's not how we do it, so we should actually be reflective of what works in our environment. These are the simple things that we can do to make our training more systems based. So as we loaded those premature twins that night onto the Royal Flying Doctor Service plane, both were stable. One was intubated, one was on non-invasive respiratory support. They had IV fluids running, they'd had their IV antibiotics, their gases were good. Our performance felt like a success. Sure, there were many disruptions to the retrieval, including the kangaroos who we had to chase off the airstrip just before our departure. But when our training is focused on not just the individual but on the system, when our scope of training is widened, when we think about what is good learning to us, then better training will occur with safe and successful outcomes. Thanks.